give just a brief reason regarding what organization they represent and what their connection with telehealth is. So, Mr. McGill?
Okay, well, I'm John McGill. I'm the State Mental Health Director here in South Carolina. And quite frankly, I'm excited that you would include someone with my limited capability up here.
He's making it hard to follow him already. Trip Jennings, I serve as the Chief Value and Informatics Officer at Palmetto Health. Was a former medical director at Health and Human Services as well. And one of the areas that I support, I guess really historically and current, is telehealth.
So I'm Meera Narasimhan. You've heard me all day long today, and I'm the Associate Provost for Health Sciences at the University of South Carolina. I'm also the Chair of Psychiatry within the Palmetto Health USC Medical Group, and clearly intimately involved with telehealth in various capacities.
Hello, I'm Jimmy McElligott. I'm the medical director for telehealth at MUSC, and I have the pleasure of being one of the co-chairs for the South Carolina Telehealth Alliance Advisory Council.
Good afternoon. I'm Steve Gardner. I'm the current chairman, president of the South Carolina Board of Medical Examiners, and I'm pleased to be here to see the tremendous amount of progress that's been made in this area over the last few years. It's astonishing. So thank you.
Originally, the panel was supposed to have two legislators on it. One was Representative Smith, who was here earlier but had to leave. The other is Senator Alexander, who I don't believe has yet made it in. So we're going to skip some of the questions that were supposedly directed specifically at the legislators and start actually with Dr. McElligott as his role as the co-chair of the South Carolina Telehealth Alliance. And I'm going to ask each panelist to respond to this question too. As you look at South Carolina and telehealth in South Carolina, what do you currently think are the two greatest opportunities to use telehealth in a way that's effective?
Well, so I have basically one is sort of more about what we're doing, and then one more. There are more modalities to come, but I think there's sort of a philosophy behind it. The first one, though, is I think that we're doing a lot. We've built a lot of infrastructure. It's taken a lot. We're doing a great job working together and behind the scenes trying to make sure that's meaningful. I think it's really talking about being ever more data-driven. I really think that we have to look at the what we're doing in the context of the South Carolinians being the denominator, whether it be a county or a high-risk population. We really need to, now that things are built and moving, they need to be moving a very meaningful needle. That was the intent of what we set out to do. So that's more the same, but in a good direction. So focus on the outcomes. The second one, though, I think is for a long time we've been very focused on video, and we still should be, and there's a lot of value in it. But I think we really need to have an eye towards how safely and tied in with video and in-person care the asynchronous modalities can be. Because we all know that most of our patients don't like to order pizza even by picking up the phone anymore and those kind of things. But there's a lot of efficiencies that can be garnered from adding the ability to communicate between two parties. And it may be doctor to doctor. It may be a big one to come as well. But I think just looking outside the box of what technology and communication can get us.
Mr. McGill, can you speak to it?
This might sound like an overstatement, but I really don't believe it is. I think the advent of telehealth is almost akin to an inflection moment in the delivery of healthcare services worldwide, nationwide, and in our own state. And by an inflection moment, it means you've stumbled upon something that has the ability to totally transform how you deliver service to people. And so in healthcare, I don't think there's any limit to what you can do in telehealth if we figure out a way to, while we keep quality, get more providers involved in the delivery of it. And then what we're doing is maximizing the ability to provide things for people who otherwise, frankly, would not have that opportunity to get it. So later when we talk, I'm going to tell you a little bit about how we're trying to do that in our agency. and how we're trying to align what we're doing with an overall state effort and our involvement with the Alliance.
Yeah, I think they did. So the big picture for telehealth and where's the biggest opportunity, I think is kind of how I viewed that question. Quite candidly, I think it's care management in all its totality. And I made a comment last year that, hopefully in a few years we wouldn't have a telehealth summit. And the reason I said that was because it would be baked into the care that we provide. We don't have a stethoscope summit. It would be just something that we do. And in general, if you're doing it to care for the patient the right way and you're reimbursed for it the right way, then you're going to choose the best modality. That's a patient-clinician interaction decision point. But if we continue to have new services that come on, and this is the ironic thing, you might think me saying this, and keep trying to pay for things fee-for-service instead of the whole care for the patient, then we're kind of saying one thing, but we'll walk in a different direction. And so we really got to look at building these things in, not as separate fee-for-service, but how do we care for the whole patient? And how do we stick to that? I mean, even, I go against that statement many, many times during the day, saying we can't stand up this program without having a return on investment, and this is what we're going to base it on. But with all of that and that bigger picture view, I think if we can get telehealth where it's a part of the entire care management of a patient, and we have the reimbursement that is around the health of a patient, not just the acute disease state, then we're going to do some pretty cool things.
No, I think we are very fortunate in the state of South Carolina to have kind of, various agencies, various stakeholders, as I mentioned, working together. To me, it's like it's also about what are the resources that we have across the state in being able to take a look at some of these hotspots. How do we go about addressing that in an integrated fashion? It's all about integrated care. We can't work in silos anymore. How do you then start to work on chronic disease management? It's not, you don't see a person just with stroke. You'll have an individual who comes with stroke, cardiovascular disease, depression. And if you look at the top three, kind of, the highest economic burden for the state, it's diabetes, congestive heart failure, and depression. So I think it's important for us to start working along those lines. At least let's start with these, 3 or 4 that we kind of end up picking and trying to kind of pool our resources to be able to then start working along those lines. And outcomes are key. Jimmy, I couldn't agree more. I know kind of, return on investment. What do we have to show at the end of the day? I know the 2 legislators, if we have the taxpayers' monies being poured into this, what is the accountability? What have we been able to demonstrate in terms of value that this brings to the state as such?
Thank you. Dr. Gardner, now hang on just a second, because I've got a separate question for you, unless you want to answer that one, because it has specifically to do with the Board of Medical Examiners. And
I'd like to answer the first question first. I'll practice my Stephen Covey up here. Let's do the first thing first. So I looked at this, and what are opportunities? Well, they're just a chance to do something better, right? So for me, it comes down to the personal and the professional. On a personal level, I'm from Greenville, right? G Vegas, right? We're up there. We got a huge rural community. Tom Alexander and I share a lake together, so to speak. On the personal side, it's an opportunity to have my neighbors get health care. The health care comes to them. I know that sounds real simple to reflect what's been said, but it is an inflection moment. As the world becomes increasingly digitized and virtual, this is what people know. They watch TV all day. And so it's an opportunity for us to expand and create access for care in a meaningful way to people. On the professional side, I have seen what I call practice drift. I'm pretty old school, you can tell by the hairstyle, and I won't say that I studied under an oil lamp in medical school, but the corporatization of medicine at the professional level has eroded some doctors' professional values. Not all, but some. And with the establishment of a different modality of medical care, we can reestablish some of those professional principles of health care. Virtual care is going to be open to inspection. So you'll be practicing in a more public arena if you're a professional. This is going to inspire you perhaps to practice to a higher level. And as we move into this digital care era, the telehealth, the telemedical, I mean, telemedical communication has been around since they were reading x-rays in India overnight 25 years ago. That's not telemedicine, that's just consultative services. So the opportunity is personal and it's professional, and that we can establish the high standards in a more cost-effective way for people. I truly believe this. And it's going to lead to integrated care, because I remember when computers came into my hospital and into my practice, and you'd make rounds in the morning and everybody's hunkered over a computer in their little silo and nobody's talking to anybody and they're sending emails and nobody's reading and so on and so forth. So I think we have an opportunity to get more integrated at a professional level to a higher standard as we work through this and break down these silos of care. So that's really it for me. I mean, it's a personal thing. I'm hoping I'll be able to get telehealth care and not have to go see the doctor 50 miles away, and I hope my profession will benefit. So that's my answer.
Thank you. So I'm going to ask you the second question then, and it pertains to your responsibility as Board of Medical Examiners.
Right.
And we know that there were a lot of challenges in managing and overseeing telehealth in South Carolina. So
That would be
what are the-
question 7.
Well,
more or less.
question 2 and 7, yeah,
Yeah,
or
right.
3 and 7. But
So
yes,
the way we got to telehealth legislation was through the effort of a lot of people who had the same values. I want to thank Dr. McElligott here. He was very instrumental in helping us develop what was first a telemedical policy, and then we subsequently were able to develop that into telemedical legislation. And we based it on several principles. One, it had to have the highest standard of care, that the care that was delivered in a virtual environment had to be equal to and significantly not different from that which you would deliver in person. And we just sort of spun off from that. We realized that there would be the opportunity for people to erode their standards in a virtual world because there's no accountability. So we had to legislate that in. But this all goes back to the idea at the Board of Medical Examiners that although we regulate and we don't legislate, which is almost carved in stone over there, my idea was to create a benevolent regulatory environment. Benevolent for the patients, for the physicians who practice, for the people who have to pay for it. Everything should be a benefit to the common good. And when the opportunity came to address telemedicine, it all started basically off of the prescribing part of it. That was the nugget that got it started. Well, you're on call, patients call you, you make medical decisions, you prescribe, used to be able to call in certain medications to the pharmacy. So how do we convert that into a true, documentable, high-level healthcare standard? And that's how we did it, and that's how we came about it. So our view at the medical board is we view this as, again, as a great opportunity to address the standards of care in the new virtual environment, to maintain those standards, and to increase access and competency of care to our patients. Those are big words and broad statements, but that's generally the principle. And that's how we got there. And we were fortunate enough, I mean, as I say, people on this panel, people in this audience, all contributed to us in a meaningful way. So it wasn't like we just had this bright idea one morning. It didn't work that way. So thank you for that opportunity to praise others for their work in this. Appreciate it.
great. Mr. McGill, grab a microphone. So from the perspective of the Department of Mental Health, how do you think we can expand telehealth in South Carolina to support more integrated use in the community?
That's a good question. Before addressing it directly, has Dr. Brenda Ratliff, have you been introduced yet? She's the medical director of our telepsychiatry program and other colleagues there. And she and Ed Spencer have done an enormous amount of work in this. And Dr. Baylog has come along recently. And I bring that up because that's kind of what we've decided that we were going to do. The ER telepsychiatry program has been very successful. No doubt about it. 27,500, is that right, Ed? 33,000, you can see I can't count either, but And that's great. And I had nothing to do with it other than the dream. I was dreaming about how we might be able to help those patients in those ERs. But the fact remains the majority of the patients that we treat are in the community and are not hitting ERs. They're going to the local mental health centers, clinics, or they're in private practices, or they're in FQHCs. So we've set about already trying to put more community or add more community focus in our telehealth program. So to wit, we're actually doing more telehealth in our community center system than we are in the ER hospital system, to the tune of almost 1,200 consultations in the community a month. So it's becoming a very big program. And our centers are all 60 of our outpatient sites have equipment, and most are beginning to use sort of an interconnectedness telehealth system within our centers. So what are we doing for the rest of the world? And that's what I'm suggesting. I think without trying to reach too far out, we're going to have to realize that everybody's not going to come to us and our system. They're not all going to be in ERs. So we're going to have to stretch our system to make it available, as it will, to other healthcare entities that need psychiatric consultation and input. And that could include organized systems of care like FQHCs perhaps, or other agencies. But my vision is to figure out a way in years to come that individual community medical practices might be able to benefit from our statewide system, because not only do we have 150,000 patients a year, we have the data capability to really assist some private offices with people that they're trying to manage on their own. So that's kind of my vision, and that would be the next iteration with what you see we do.
Just to add, if you look at the United States, there are only about 5 or 6 centralized departments of mental health. We're very fortunate to be in a state which clearly has a centralized department of mental health. The same agency running the inpatient, outpatient facilities and working so collaboratively with others. So if you look at, as Mr. Magill mentioned earlier, so if you look at neurotic disorders, depression, anxiety, very frequently are captured within the primary care settings. So they may not even kind of touch the Department of Mental Health as such. The SPMI, severe persistently mentally ill, is the one that end up going to the public sector, the Department of Mental Health. So there needs to be a way in which they don't have all the resources in the state to be able to address every mental health or behavioral health needs. So I think it needs to be coming together of people to be able to kind of then say, okay, how do we go about addressing this in a collective way so that we can help address, clearly the unmet need that exists out there. And I gave you the stats, 10 to 12 psychiatrists per 100,000 in the state of South Carolina, compared to 15 to 17 per 100,000 in the state of Maine, which has 1/3 of our population. What we also found with the statewide ED telepsychiatry was that just kind of by this, having the presence of a telepsychiatrist in there, it also improved the telehealth literacy of folks in terms of resources within their own communities. You might have had a mental health center in your backyard, but just understanding kind of how the system works. And that to me was amazing. When we started to do these surveys, staff and provider surveys, that was the one which was like at a 40% when we began. Now it's at an 80%. So people getting to know what resources exist out there within their own communities is extremely helpful. Also, how do we then, as I mentioned earlier, all of the mental health needs cannot be addressed by psychiatrists. We also have to have primary care physicians who can address garden variety depression, anxiety. So what we ended up doing, as you kind of get to treat these individuals, are there folks who are going to be referred to who are more significantly refractory or resistant to treatment versus those who can be treated by an ED physician. Trip, you are an ED physician. So I think very often if there is a way in which an algorithm that we can develop wherein we can help together kind of start to address some of these needs that exist without having just an agency addressing those needs, I think that really needs to be the way forward.
Thank you. So, Dr. Jennings, I'm going to ask you a question that's somewhat related, what do you feel that we, the collective we, can do to encourage the use of telehealth in rural and underserved communities to support better primary care as well as deliver specialty care?
So the challenges in the rural and underserved areas might have a different weighting than in other areas. But I bet you if we listed all of them, a lot of them would be some of the same challenges we run into implementing telehealth in the urban areas. The needs of the community are, they frequently don't have access, as we know, we've talked about a lot, and they might not have the providers or have a worse situation with the types of providers that they need in that area. So this isn't, when you think about it that way, it's not very complicated. We need to know what the rural health needs are, and then we need to come up with a plan to address those, and then we need to figure out how telehealth fits into that. Now that last one is when it gets complicated, because that's when you get into the reimbursement side. That's when you get into a lot of the regulatory things, which are very, very important early on. So I think we need to understand, first and foremost, what are our needs. And we've been blessed to have a consulting team that works with us early on in the development of our strategy. And one of the things that they were very good at is they always said, what problem are you trying to solve? Because if you come in and if somebody comes to you and says, hey, I want to do telehealth, you should be scared right away, because you don't do telehealth just for the sake of doing telehealth. For those of us in administrative positions, we get that all the time. And it really does set you up for failure. They need to articulate what the problem is. And so I would go back to the roots and say, what problems do we have? Just saying access a lot of times is not near enough, because you can meet access needs many, many different ways. And many, many times one solution might be better for the patient and cheaper, for the health system in general. So know what the needs are. Don't just say access. We need to know access for what. And also, we make a big deal about the competency of patients out in the rural areas versus other areas, and there's no literature really to support that. There are some age things that we talk about, but again, with the solutions that we've deployed, we've seen many, many people using them that they're over 65. And so we need to understand what we're trying to do and who we're trying to do it with, and then figure out how to solve the problem, and then how telehealth fits into that.
Dr. McElligott, do you have anything to add to that on delivering care in rural environments?
No, well, I certainly agree with everything said, and I certainly think focusing on the problems and not doing telehealth's sake is a really strong statement that we all should heed. I think there are unique challenges of if you're deciding if you're trying to get more primary care or augment, say, a primary care doctor's practice and give them more tools to get more done. There are limitations. These are busy practitioners if they're in their communities. So it does take a little bit of care and attention to figure out how it works in those environments. And it seems like the smaller community or the smaller hospital you go to, the more you have to pay attention to the individuals and the history and those kind of things. So coming from an urban area and moving into one of these areas, you have to do it with care, I guess is all I would say. And I think there are right-sized solutions that can be problem-focused based on needs that will fit better into the workflow of these practices or into the needs of these communities that are versions of what we're currently offering. But by paying attention to the rural communities, I think we can morph. I think one note is that this is a grand quality improvement project. So it's not that this was set forth, did it work or not? It's what are the goals and how do we change what we do to get the job done? So that's the biggest thing. And if I may, just for a second, because we have Dr. Gardner here, and he's been so gracious with all of these things, I wanted to make sure it wasn't lost on us that our Telemedicine Act is focused on good practice in medicine. That seems simple, but throughout the country, a lot of it is tied to locations, types of technology, and it's tied up in payment. We have a Telemedicine Act that's focused on quality and maintaining the integrity of the local care system, and it also provides it also kicks back to the licensing boards to make some judgments based on standard of care. And that allows us to have the right focus, to keep focusing on medicine as we bring these. So I just wanted to make sure that wasn't lost. It's, we don't have your average telemedicine act. We have one that is, I think, built to last the ages.
That's great. That's great. So, so So, Dr. Gardner, you said a little bit earlier that the role of the Board of Medical Examiners is a regulatory function and not a legislative function. As you kind of have been here and looked at telehealth and all those things, is there a role that the Board of Medical Examiners is going to play to help it evolve in the state of South Carolina?
Well, absolutely. I mean, Jimmy said a lot for the board that we appreciate, who is critical in the passing of the act. There are two challenges, though, that we sort of have to deal with. The first is integrating this data and healthcare. Because you've got episodic telemedicine going on, the teledocs. You've got care of chronic conditions going on. You've got mental health issues. So to integrate all that in a meaningful way is a little bit difficult. I mean, healthcare systems are data-driven. They're driven by various digitized versions of that. So the integration of this is going to be one of the challenges that we have. And as we integrate it, we don't want to lose the quality. The second part of it is going to be, that's going to be big data. And nobody, I mean, I'm sure there's been a session on this, but no one's really talked about the security of the healthcare data and medical fraud and the many things that come as you centralize the care in an electronic means. I mean, people do get hacked, occasionally on a personal level and on a bigger level. So the integration of the information and the security of it are going to be critical. Those are going to be challenges I think we can meet fairly easily, but we don't want to get sidetracked by the technology and replace our interest in the technology with delivering good health care. So that's the first, those are the challenges I see. Our role as the BME is safety, safety, and safety. I mean, that is a pretty low bar to obtain, but it's a necessary bar. I mean, you can be competent, and you can have access, and you can have all these wonderful things that telemedicine can bring, but if it's not done safely, in the end, you really just have convenience. And so that is the real thing the BME is about, is how do we maintain safety as we progress? It's interesting to note that the progress has been so rapid with good programs in this state. I mean, really good programs that are done safely, they're done right, but they're getting a little bit ahead of the law as we speak. And so we don't want the regulatory environment to be an anchor or a drag on the development of improving healthcare in the telemedical world. So we're working pretty hard with everybody. We've got stakeholders everywhere trying to make sure that the regulatory environment is benevolent and that it keeps up with what's going to be best for the telehealth delivery in South Carolina.
Okay,
Did I answer the question, or
You
did I
did.
get off track?
No, you did. Thank you
I
very
had an
much.
extra cup of coffee, and I could have veered off track.
So I'm going to ask this question of all of you, and I guess we'll start with Mr. McGill and work our way down. What do you see the role of your organization in working to increase the use and availability of telehealth services in South Carolina?
Well, I addressed some of that in the prior question that had to do with more involvement and more access in the community. But I have to put a qualifier on it that sort of touches on this, and that is there's an endpoint with how much resources can be given to state agencies like mine. If Thomas and Merle were here, they would tell you I wouldn't even have telepsychiatry at DMH if it wasn't for the Duke Endowment. They're the ones who did all the funding. So we're going to have to figure out a way to expand, create better access while we keep quality standards in place. But we're going to have to do it in a way that ultimately pays for itself. And I sort of hate to bring that up at this point, but the bottom line is there is just an end point in how much public money you can put into the ventures we're all doing. So we've got to figure out a way to sustain what we're doing. And the key to that is going to be what Mira said. It's going to have to be done in a qualitative way. We're going to have outcomes that justify what we're doing and meet all clinical standards. So that I'm trying to keep within how we're doing our telepsych. And Mira's been involved in doing a lot of studies. Our ER telepsych might be one of the most rigorously researched of any of the telehealth programs, and the results are quite good. So I want to keep our expansion at the level of quality and efficacy that we've done thus far.
So I guess the role of the health system, I'll take it kind of as a from that lens. Our CEO, I'm blessed to have to work with a CEO who made this comment, and I think he and Tony Keck actually both used to make this comment that, you know, what if we viewed an admission to the hospital as a failure of the health system? And that's a pretty dramatic statement. A corollary to that is, well, what if we were reimbursed for health instead of for sickness? And currently our health system is such, and health systems and the healthcare system in general is set up so that we get reimbursed when people are sick. Now, some of those things are starting to change. We're starting to see value-based care. I think the role of the health system is to figure out how do we start to transition from one fee-for-service world to value-based care. And if you don't think that telehealth and innovative and integrative technologies are going to be a critical role in that, then I must be missing something, because that is one of the key things. We know some people get sick when they come to the hospitals. There's harm. There's other things that happen. It's a place full of sick people. You can get sick there. Unfortunately, there are harms that happen in hospitals. So how do we start to limit those people coming in? Well, it's by adopting technologies like this. And I do feel blessed that not only do we have a state where the legislature has invested or planned on invested up to $50 million into telehealth. How do we start to make sure that we capture that, and the health systems as well invest in flipping from one mode to another? And so I think leading that and having candid conversations is one of the ways that we can really step forward.
As I'd mentioned earlier this morning, so we've been involved as USC and Palmetto Health USC medical group in a number of ways with regards to outcomes within the statewide ED telepsychiatry. We've kind of expanded it to rural counties within the state based on the needs. And again, the two policymakers, both Representative Smith as well as Tom Alexander, have clearly kind of supported many of these initiatives to be able to then expand it. I have to kind of, again, mention here that we have to be prudent with regards to kind of clinicians and the human capital that we have, resources that we have, as well as being fiscally, being aware and prudent of the fact that how do you match what you have currently to some of the needs that exist. We fully realize that no one agency, no one institution can meet the healthcare needs of the state. So figuring out what works best for kind of some of the needs that do exist. And as I had stated earlier, we have partnerships with various state agencies, Department of Juvenile Justice, Department of Corrections, trying to look at how do we go about addressing those needs. Within the Rural Health Initiative, we have not just within psychiatry, but I can also speak for neurology, infectious disease, which clearly has a presence in various rural counties, as well as pediatrics, which are in the process of trying to look at kind of, telehealth, in addition to being there in person in some of the rural counties, be it Orangeburg kind of comes to mind. So I think it needs to be a way of kind of trying to match what resources we have, and then what are the unmet needs. Unless we have either grant funding or kind of, state appropriations, it's going to be very difficult. At the same time, we also need to be aware of making sure that it's sustainable, whether it is in terms of reimbursement that we go on to receive, cost savings that we can go on to demonstrate, kind of value-based care that Tripp mentioned earlier. And I think all of this comes together. So I think it truly requires all of us, again, coming together in making sure that even though we are functioning as individual institutions, facilities, and agencies, we really need to take a look at this healthcare landscape, the various needs that we do have, and how do we go about prudently addressing some of those
You have anything to say, Jimmy?
They've said it mostly. I think the theme is that this has to be more efficient. We want to do more care. We want to do better care, but it has to be lower cost. And all of fitting into value-based care and whatever may come about how things are getting reimbursed, at its core, that the new system has to be more efficient than the old system, and it may be more efficient for handling a population, or it may be more efficient for handling an individual patient. And so I think that's the core of what we have to do. And I guess the only other caveat is that, you know, the state has entrusted MUSC, but also entrusted all of us to get a job done. We get to decide that needs to be efficient healthcare, but we also do have to take this rare opportunity in history to really have pride in the work that we do and take it very seriously.
Dr. Gardner?
It may be a little bit out of my wheelhouse. What I would say is that the BME would attempt to keep any regulatory imperatives and costs at a bare minimum as long as safety was maintained. We build that in. I've also noted that this may be just from a sort of an entrepreneurial viewpoint. This may be an excellent opportunity to partner with those that pay in a meaningful way directly. If you have healthcare issues that affect large employed populations, for instance, Boeing, think Boeing. In my area of the woods, it's BMW and Michelin and people like that. And I think that these corporate partners would be able to work with us under telehealth care provisos to cut their health costs. And that's sort of a mini model, but it's a very economic model for the local communities in which they're in. So I don't think we need to just think in terms of, well, telehealth is getting rid of bricks and mortar. You know, the patient doesn't need to come to the hospital anymore. It's way more than that. I mean, you're going to save the bricks and mortar cost, sure, but it allows you to focus the monies that are going to be spent on particular problems that a corporation may have or a local community may have to reflect back to my colleague, what is the problem and what do we need to do? So I think there's a huge economic opportunity here, and I would almost pledge, although I probably can't quite do that the regulatory cost would be try to keep it at a minimum. We certainly will.
Thank you very much. You know, I just want to actually reemphasize something that Dr. Jennings said, because I think we sometimes forget that a lot. And in full disclosure, my name's Will Harms. I'm the Vice President for Medical Affairs at Blue Cross Blue Shield of South Carolina. So we're a fairly significant payer in our community. And I think we frequently forget the importance of health when we focus on sickness. And I really think this is a huge opportunity to actually cast a different light on health, because to Dr. Jennings' point, I've told people frequently we shouldn't call what we sell health insurance. It should be sickness insurance, because we really don't do much to insure health. So one last question, and then we'll open it up for audience response. And Dr. Gardner, we're going to start with you this time, going the other way. And this has to do with, as you look out in the audience and all of the various stakeholders that are represented here, is there somebody who's not here, some organization or care provider who should be at the table with us as a stakeholder for telehealth?
You can always use more good stakeholders. I mean, obviously. I think that the regulatory representation is a necessity so that you're aware of what the current statutory environment is and so that we don't get it ahead of the law, as I've said. But in the development of this, we really need to consider our ancillary health providers all the way up and down the combined care team. You know, there's been a lot of talk about physician this or that. It's a team approach, and we need to get all the team members, because each of those teams will have particular areas in the telehealth arena where they may be able to exhibit expertise or they may need guidance. And so we need to consider ancillary health professionals all up and down the line. That would be the stakeholders that I would invite in next.
Jimmy, you probably know as much about this as anybody, so do we have everybody at the table that should be here?
I don't think we really represent the patients here as well as we should. but they shouldn't have a say. No. And honestly, we're limited by Medicare. I think we need federal changes as well to allow us to grow more in some ways. Without the investment from the state, a lot of this wouldn't be possible because of such restrictions. So, but I would, I want to give a shout out for some of the folks that I've met throughout this summit. I met folks from free clinics and a number of other areas, and the word's getting out that people can use this to address some of their issues. And so I think we're pretty inclusive as a healthcare community. I imagine there's other folks to bring in, the large companies and things like that. Certainly employers, we haven't gotten there as well as we should. But if the glaring thing is we don't have enough voices from the patients.
Kind of, talk outside of health here. I think there need to be stakeholders, a transdisciplinary kind of, group of stakeholders, which includes computer scientists. You're talking about cybersecurity. Safety, security, privacy needs to be at the heart of all of this. How do you get them involved in this kind of initiative across the state? And I think, to me, that's going to be key in kind of trying to translate some of this. The other is the business group, in terms of health economists, who really need to be a part and parcel of this. Are there folks from the schools of business? We have the Moore School of Business right here at USC. Are there folks that clearly need to be a part of that, to be able to help advise, kind of, where does this, how do we follow the money trail? Where do we really need to kind of get this within the state?
So I was trying to think of something brilliant. So it's probably not going to come out that way. But the first thing, two things. The first thing is I think we need more, which is kind of the obvious, just more. We do have a great cross-section of stakeholders here, but I think we need to be more and more involved in all aspects of healthcare. So it's not looked at as a telehealth community, but it's embedded into the whole healthcare system. The other thing, the brilliant thing that won't be so, is maybe kids. Maybe we need to look at the way that the younger generation, I won't classify it any other way other than saying the younger generation looks at technology as a way just to get through things. And I'm thinking about my own kids. And even though I'm definitely a tech geek, my kids teach me stuff all the time about this is simple to do. They just think differently. And so if we can start to apply that kind of logic, that kind of common sense logic, with a group of people who haven't been contaminated by our current system. And contaminated sounds really strong, but I think we all are. It's even hard for me to get out of the fee-for-service mindset. It's hard for me not to always think about regulations when everything I do. Somebody comes to you with a great idea, the first thing that's going through my head is why it won't work. All of these reasons why it won't work, and it's not because it's not a great idea and it'll solve the problem. It's because it's going to be hard. And so maybe let's look for some people who haven't been exposed to that. I think that would be a good group to have. I don't know who they are other than our kids, but some group like that.
Y'all gave excellent answers. And really, I agree with actually everything you've said. I thought it was well put, the groups that needed to be here. And I had a flashback, and I'm going to have to tell you about it. I was sitting here thinking, right out of graduate school, not knowing anything, I was thrust in the old state hospital in 1968, 69. I had thousands of patients back there that I was supposed to do something with. And I know how we delivered care then. And then I look at today and now, and I think, could anybody have dreamt in the late 60s that we would be delivering so much care today through telehealth? And the answer is certainly not me, but there may have been some dreamers there. There may have been people who asked, why not? Why can't we do something new, different, exciting? And so my admonition would be, with all the other people that we have involved in healthcare as well as other endeavors, let's also have some dreamers, some people that really are not totally bound by the lines that we all have to color within.
So we've been joined by Senator Alexander. And I would actually like to offer you an opportunity to give us kind of a legislative perspective on telehealth if you want to, or we can go down these questions one by one.
Either way, I was hoping you already had all the hard questions resolved before I
do.
got you. That's the reason I was waiting to get here. No, not really. I'm sorry that I had to be late due to meetings and things. Well, I just think that obviously I think the coalition and the alliance and folks working together and having the partnerships has certainly been beneficial to telemedicine and trying to move the ball down the court. It's been interesting to hear some of the challenges or opportunities that you realize and having data and then what to do with it. But I think that for me, the perspective on telemedicine, telehealth has been from the standpoint of being from a rural part of the state to understand up front how valuable it will be to our future. And I think that as we roll out and continue to deal with the expansion of those programs is make sure we get it right. I think that the model that Mr. Magill and the folks over at Department of Mental Health through their telepsych was a great roadmap to begin with. I think there's great opportunities, not only we think about the primary care and the specialties and the different things of bringing partners together, but then you think about the prison population. There's a lot of opportunities, I think, that we can certainly bring together the opportunities to continue to build out the network. And at the same time, then it becomes, I know one of the questions was about payment. Seems like it always gets around to money and to payment, things of that nature. So there are always those types of challenges. I do think that overall the legislature has been very supportive and responsive to what we're trying to achieve from that standpoint. And so I think that having the right players and the right folks involved is critical to the success going forward. So I think from a legislative standpoint is we want to make sure that, or at least I do, let me say from my perspective, that when we look back, or whoever looks back 20 or 30 years from now, and they look at, they said that we did it right, and that we're better served, our citizens are better served as a result of that. I know there are challenges getting it out into the rural aspects of our state, and so, you know, that's where I think these types of initiatives and opportunities to have dialogue are very important to us from that standpoint as well.
Thank you. So we're going to, again, open it up for questions. I saw a hand. Yes, ma'am. So
Do you want us to answer that for you?
yeah, go ahead. No. So actually, I can tell you with absolute certainty that Blue Cross Blue Shield of South Carolina is 100% interested in the delivery of telehealth services in the state of South Carolina. As it turns out for our employer groups, many of them are self-insured, and their primary interest right now is in what I guess you would call urgent care in the cloud, because everybody looks at their ER visits and they say, gosh, why do we pay for all these things? We look at them, you know, you looked at records on these, and they didn't really have a particular reason to go there. They had a medical issue, but it didn't need to be dealt with in the acute emergency room. So there's a lot of our employers that are interested in that. We believe there's a huge amount of opportunity otherwise. I mean, a number of services have been mentioned. We think it's an opportunity to get better support for primary care physicians where they are and where their patients are, rather than require specialty care to be provided in a doctor's office in a remote city from where the patient lives. So we're actually very supportive and love to hear from health systems that have some ideas about putting forth a way to provide patient care, delivering specialty services that don't require the patient to travel. And, you know, over time with wearables and peripherals and other devices, a lot more appropriate medical information will be able to be transferred from a patient 200 miles away to a specialist who has a unique ability to provide care for them and won't require a trip. I think actually Dr. Foster mentioned, having to weigh whether it's worth a 2-hour trip each way to go see a doctor, and we'd like that to not be on people's minds. Generally, when we interact with a self-insured employer and they're looking at how they're going to cover things, we sort of have a standard template of what we would suggest they cover, and they have the option to say yes or no, or to cover things that we don't believe particularly have value. And certainly, telemedicine and telehealth are part of what we would suggest everybody consider. They don't all, but we always suggest that.
I think it also begs the question, I know we were having a conversation, Commissioner Clyburn, about kind of telehealth literacy. How do we kind of involve business groups across the state to be able to kind of, talk to them about some of the wonderful work that's already been showcased within ETV here? And I think that's going to be key in moving forward. At the same time, also, I think we have to have pilots, just like what we had with the statewide telehealth, telepsychiatry initiative, which we've been a part of. How do health systems take a look at their own employees? How do we start to reduce kind of, absenteeism? What is the cost associated with that? So I think those are key issues that kind of healthcare systems across businesses need to kind of, be invested in to be able to translate this into action.
I would suggest that what Dr. Narissima is saying is a perfect way. Get a business model in a business. Show the economic model and the benefit of it, and that'll go a longer ways than all of us talking about it up here.
And if I could follow up, that's exactly what I was going to, one of the things I was going to suggest, because I do know that the other model of having those health professionals in the industry location, that's how it got started, was having a good model and getting good results, good outcomes, and saving money. I don't know whether there's some maybe states out west or someone that has been on the cutting edge of going to that next level where that work on a pilot basis has already been done, that you can show the reduction in absenteeism and cost savings and things. So rather than having to, I agree that pilots within the state would be good, but if somebody else has something that's already been successful, that could also jumpstart for industry here in the state of South Carolina. But I do think that is a great place for us to go with telemedicine.
So a couple of things. One, I think several have mentioned the importance of us actually sort of showing the benefit in sort of hard quantifiable data as opposed to just speculative data. So I think a number on the panel are very interested in sort of getting to showing the value. I mean, everybody believes it there, but if it's there, we should be able to find a way to measure it and deliver it. The other thing I would offer to you is for self-insured for self-insured companies that actually pay their own health benefits, many of their decisions are actually driven by benefit consulting agencies, and they're always chasing something different because they want to be able to appear to be able to create value because they said what we did last year, you should do something different this year because it'll be better. So we, on the insured side, when we are the benefit administrator, we actually administrate the benefits for the self-insured clients. It's always a battle for us to try and not let the benefit consultants be, to disintermediate what we think would be of best help to the employer group.
Just a comment too, I would say, the discussion on the employers, it rings true for the schools and the correctional facilities. And what rings true is that you have your population in a more, for lack of a better term, captive environment, I suppose. I'm saying the kids are captive, but I guess the point being, we can do something. But I think what gets, and then what I see happening, even in relationships with insurers and things, is we have good, meaningful data, and now we finally have like the word I love, that denominator, to try to figure out, okay, where's the needle that gets moved, so that we know that we're moving in the right direction. And a lot of times we're one step short. We get to like Dr. Foster earlier in this summit was talking about a study that came out that showed that for upper respiratory infections, telehealth is increasing some costs. But the next step, which Dr. Foster also was alluding to, is what's the downstream value of more interaction with the healthcare system? And at what point does a person's increased interaction benefit us? And if it's reduced emergency room visits, well, your intervention better be designed to do so, at least at some stage, and it can't just open it up and make it happen. The other part is if 50 years from now, the preventive care that you've tagged on to that modality allows more people to get more colonoscopies, you're going to have to start thinking about these things. And when you use the cost savings, the one extra step that I find we need to dive a little deeper is, if we say a length of stay in a hospital is less, and each length of a day you stay in a hospital saves you X amount of dollars, those are real dollars by real mathematicians or real statisticians. But when you go and talk to a hospital CEO, unless they're cutting out a room or letting one nurse go home from their shift early, there real changes in cost savings to the hospital. You have to study it or go that extra step to have the data that is meaningful to the stakeholder that has to see it on his budget actually go down. So I've heard a number of CEOs say, if you added up all the cost savings they ever had, we should be rich.
Yeah, isn't that true? So, any other questions?
I was going to make one statement.
Okay.
You asked such a great question with the stakeholders because it's just one of those things that keeps us all thinking. And I'm blessed to have some of our legal team here, but I think we definitely need more legal expertise. We get kind of talking, I guess some different kinds of lectures when we come to these events, but having our own teams here in the audience, even Dr. Gardner has no idea how many times his name has been used across the state in a good way. When when an idea comes up and somebody says something about Greenville, and the question is, has Dr. Gardner seen it? Because he's got a perspective of what's the regulatory need and also forward thinking around, how can we get this in? I can't tell you how many times I've been asked legal questions, and my legal team will absolutely support this. I don't need to be answering legal questions. I will always err on the more open side, I guess, than the strict side. But I see that as kind of my role. So we need to have a collaborative effort of people here who understand not just us, the believers, but the other people who are the warriors, who are concerned about it. And I think that would help us get further quicker.
Yes, another question.
So my question is, what is being done to educate the public and the misconception that can be spread, especially through things like social media? If you don't have the public's buy-in, everything we're doing here does not matter. And so I didn't know if there was any initiatives or anything to get out there, piggybacking on what y'all have said with, talking in the schools and with the employers, but once something spreads on social media and you've got misconceptions and incorrect information going out there, then all of a sudden you have this, out of control and spreads like wildfire idea that telemedicine is, for instance, illegal, or it's not real medicine, and so then it defeats all the efforts we're making.
I guess I'll take that one for a second anyway while they think.
SCETV. Keep going. SCETV. Keep going.
Yes, so with one of the primary statewide strategies is promotion, and that's to providers and to patients as well. And your point is well taken. There's a lot of work to be done. The survey that was done, the needs assessment showed that the knowledge of telehealth is very low. But I would say that the legislators, in fact, had the foresight several years ago to include SCETV in the plans. And at the time, I'll be honest, thought to myself, okay, what are they going to do? But I was wrong, and they are really at the core of what we're doing. And the videos you're seeing, the social media you're getting, and all these other things, they might be one of the most, if not the most important aspects of our team. And they have a primary strategy. So I hope it's an effective strategy, but I don't know of any other state that has the public television with them or that has a primary strategy around it.
First I heard him talk about that we had some foresight, like he was surprised that we had that foresight in the legislature to include that. But I do think it gets back to those collaborations and the industry is in the businesses. It's like so many other things in health. You really got to go to where the people are a lot of times rather than waiting for the people to come to you. And so I think that where you've got, as mentioned earlier, school districts and folks where you've got a fair amount of employees at one location, that certainly that would be a good first start, especially in rural areas. And maybe there's other community gatherings that have the ability to your point, is to be on the front line and get the factual information out there before the misinformation gets out there. Because once that misinformation's out there, believe me, having dealt with other issues, a lot of different issues where you get a lot of misinformation, it's much more difficult to deal with from that standpoint. So I would hope that there's some type of opportunity to really build that network from that standpoint. So I think that would be beneficial, and maybe it's creating something that could be provided as a program, some type of a tape or something that could be utilized by those folks and be educational from that standpoint. But I do think I agree that there is a lot of education that needs to be done so that people have a comfort level of utilizing that service in their community.
You know, Senator, how many vignettes have been done on the telehealth? 34, and they're 3 or 4 minutes. The packaging of all those in one would be a product that would very much address the point you're making, because it's excellent work they did, and so the Alliance has been very involved with trying to utilize ETV in the state. The state's got a unique ETV program, and it's good, and I hope everybody supports it.
Dr. Foster.
This nice lady has a question.
Good afternoon. My question is, what types of internal monitoring do your programs have in place to ensure that assets are protected, and particularly when you hear of all of the computer equipments, the iPhones, these iPads, what type of monitoring system do you have in place, particularly when it comes to regulations as well, or to ensure that compliance is that we're in compliance with regulations? I'm from a different perspective. Mr. McGill is actually my boss, but I'm an auditor. And I know many of you are clinical in this office, in this room today. But I think when you look at the dollars that are spent, can you tell us some of the monitoring?
And that's why that question's going to MUSC and not DMH.
No, it's a good point, and I guess there seems to be two elements to that. One is, as you open up technology, like we talked about earlier, you open up risk as well, and so data security and all those things. It's a natural part of a large enough institution that has data security as part of it. It gives them a headache, but it's their job to stay on it. I worry a little bit more as we look to use this equitably across the state, how the smaller partners deal with that and how to do risk analysis from endpoint to endpoint and things like that. And to a degree, putting out these technologies and getting other folks to do it, I think MUSC has to carry a backbone responsibility to make sure that that recommendations or whatever else is about how you use things, they have to have the highest level of security, and that equipment shouldn't go out there without the right support. So I think that we have one of our tactics under strategies is this equipment request form, for example, that the intent is to say other people can request and get equipment other than the main people at the table, but it's also to say that do you have the right folks supporting you, and if on the Greenville side of the state, maybe Greenville needs to help you, and those kind of things and that's the intent of that. I think, the other part of the question is just how do you make sure that the technology is put out there, and it's a question that we have, that we discuss in our groups and in our institutions a lot. Are we using the right technologies? Are we just populating the state with things that are going to gather dust? And unfortunately, it is hard to get some telehealth programs going sometimes, and I can't say that doesn't happen. But we try to monitor that closely, and we're trying to increasingly look at utilization. And and again, it's keeping an eye on those outcomes. So it is a work in progress, but you have to build a road for someone to drive on it. So you have to sort of build, watch, and make sure the infrastructure's there and that no one's getting something that they can't support.
So when you ask that question, and I don't know if y'all have seen, some of you have, but with some of the Hep C medications that are out there that are $100,000 a pill, there's some technologies going where employers, because if they're going to pay that much money for that, you can actually put a little device on it which tells you whether or not the patient actually took that $100,000 pill. So when you said internal monitoring, that is where I went immediately as a clinician. And I think that highlights the point of that we got some definitions and things that unless we're all in the same room to say, what are we talking about? Because literally when you started, I was like, oh, this is going to be very technical. This is good. This is internal monitoring. I like this. And then I was like, oh, it's a compliance audit, risk security question. I get that all day long. But I think that's the point. We got to get together and have these discussions. And if you watch the news, like any of us who have responsibilities over some of these things when they occur, with the Internet of Things, is amazing what you can do. It is also one of the major ways that health systems are getting hacked now. And I see a lot of IT people out there shaking their heads because they have a lot of stakeholders, of which clinicians are a big part of it, saying, we need this. Can you imagine how we can improve care with this? And then you plug something in, and then somebody nefariously figures out a way how to get into the system, and your hospital's held ransom. And that's happening. And we all, for you those who don't recognize this, the IT people from the health systems and the practices know it, we are all getting hacked all the time. I mean, everyone is always trying to get in. And it's not really that hard to do sometimes when you have all these people out there doing new, innovative, fun things. But we can't stop progress either. And so the comment Dr. Gardner made about having a safe playing field, not having too many things that are etched in concrete, etched in stone on the legislative side is important, but we also need those to protect ourselves as patients. So we got to all get together and work together and collaborate.
I think while all the healthcare systems across the state are doing the due diligence and trying to kind of look at security, safety, and privacy, as we discussed earlier with cybersecurity. Very recently, 2 weeks ago, I was in Germany, we have a sister state partnership with Kaiserslautern in South Carolina, and it's just fascinating to see how they are looking at cybersecurity. I know both USC and Clemson have a partnership with Fraunhofer Institute to look at cybersecurity. Are there implications of that to healthcare that we can, or kind of lessons that we can kind of draw from working closely with them? They're doing some amazing things. They're trying to look at smart communities within that state to be able to establish that. So not just in healthcare, shopping, other kinds of businesses. So I think I think those are the kinds of things that we really have to look at, kind of whether it is within the United States or across the globe. What are some of the lessons that we can learn to make our system more kind of secure as we progress and kind of try to provide the best we can in this digital revolution?
Great panel. I want to thank you all for spending your Friday afternoon with us. My question is, I think we've alluded to it, but I just wanted to get back to the whole issue of parity. A number of states have seen the value of telemedicine and have instituted legislation to provide parity so that people get paid for providing the service by telemedicine that they would provide face-to-face. What is it going to take for South Carolina to get to that point, for us to be able to provide to our clinicians the same incentive to provide care via telemedicine that they're providing in their offices?
That's similar to the question that Commissioner Clyburn asked me, and as you answered, I'm going to say quickly, I said one of the things that we got a challenge with is because we're still primarily a fee-for-service system, and you may say the same thing, is we think that just by telling a practice, regardless of the size, we're going to pay you more for this. We're going to add this code that they're going to jump up and down with joy and say, I'll get paid more. It just doesn't work that way. And so that model, to me, has got its own challenges. So the question would be, are there different models that create the right incentives?
And having a lens into, working at Medicaid, and then also being a provider and also being an administrator on the health system side, you start to recognize you got to be careful what you ask for. And there are some wonderful ideas that I know the DHHS team could tell you about that came to the agency of opportunities for us to really use telehealth and reimburse for it around a care model, and the systems weren't set up to do it. Even have locations of care like schools is killing payers because we had so many regulations and around the old fee-for-service model that sometimes it's not even a willingness to want to pay for it. It's they can't. Like there's no way to get the money to them. And that sounds crazy. It sounded crazy to me when I got into that world and was like, what do you mean you can't pay them? Just pay them. We don't have systems to pay them. They can't even send us a bill. We don't have those things. So you're starting to see that work has been going on for a long period of time to put in modifiers, to put in different things. Well, heck, that's making it so difficult that we're having to hire a battery of billing people to figure out how we even get money to them. And so I personally do not think that legislating a care model is the right thing to do. That's my personal opinion. Hopefully I just didn't get fired by my boss. But I think we need to come up with a way that we're trying to reimburse for health and not just service delivery. And I know that's a bunch of words, but the flip side is we have to get paid. People won't do things they don't get paid for. And so how do we approach it to say, okay, we're going to pay you for the care of this population based off of the outcomes of the health of this population, and then you can use the money for whatever you and the patient and the providers think is best. I personally would rather see us do that than to say you have to pay X for this or X for that because we quickly will be wrong. And it also is an undue pressure on the legislature, in my opinion, when they have many, many other things to focus on if we collaboratively come together. And I do feel like we've had pretty good success. I mean, in a state, I'm obviously a little bit biased working at Health and Human Services in the past, but our payers are wanting to come to the table. It's just like, bring me a good model that we can actually do. Is kind of my feel for it.
I would only say reimbursement, Rick, it's a journey. It's not a short trip. And I think we're on a journey, and I think by and large we're headed in the right direction, but it's going to take some time to implement some of the principles that Tripp's talking about.
It's a long and winding road, right? Yeah.
I said journey.
I would say too, from a legislative standpoint, if y'all can work it out, it's much better for y'all to work it out rather than looking to us to work it out. Most of the time you don't like the outcome necessarily, and I like that model you was talking about, looking at paying for the outcomes rather than the delivery of service, and it's better health, and it gives you the opportunity to get into maybe some of the social determinants of health and all of these things that are impacting health. At the end of the day, if the outcome is better, get into scope of practice. Anybody heard of those type of issues and the delivery of those things? So, it's I would encourage y'all to come up with your own model from that. And y'all are, and the folks not only here, but the other ones that have the right stakeholders in the room, those where the rubber meets the road or where the work's being done and where you understand all those things. You got to remember, when you come to the legislature for a legislative remedy, you're dealing with part-time legislators that are not familiar with your day-to-day services. And so I would, and most of the time, by the time it gets to us, it's difficult. The easy things have already been decided. Why don't y'all just come with a solution and let us bless that solution? It's wonderful when we have those opportunities to do that.
I just might make a comment real quickly on parity laws and things like that. One of the things is if we could move to value-based care quicker, certainly I think all of this would be a moot point. So I do think if we can be clever for you all and do that, that's where it needs to be. The majority of states do have parity laws, and we actually have a poster here that was done that showed that those states do actually use more telehealth. So we are looking at those things, see if they matter. But when you look at the parity laws individually, it is a careful what you wish for kind of situation. Do you want legislator this location, that location, this type of providers, this type of CPT code? What do you want in there that ends up being a compromise between the insurers and the providers when you really want your insurers and your providers working together? And so, we're trying to create that environment where we can do that, Even if you look at the American Telemedicine Association's report card on South Carolina, it's not a very favorable one. But it specifically looks at legislation. So we're looking at what would be a more realistic report card. What type of report card shows all the value that Blue Cross Blue Shield has done and what they do cover, rather than saying, oh, there's no law making Blue Cross Blue Shield do it. And so all of these things are important for us to really understand what does change, what does increase the utilization of those folks that might not be part of the alliance and those kind of things. So it's a work in progress, but legislation isn't necessarily there, but it does hinge on pace to a degree. We have to make progress.